Welcome to Medscape at HFSA 2025. I'm Dr. Martha Galati, and I'm joined here today with my colleague and dear friend, Dr. Anu Lala from Mount Sinai Fuster Heart Hospital. Welcome, Anu. Thanks for being here with me. And I thought today we could have a great time actually picking some of our highlights of two really big meetings that we've recently had that both of us have been at one of the meetings. So I was at ESC, you were at HFSA, and there was some very exciting studies that I thought we could recap today.
I know, I'm so sorry I missed you, Martha. It's always such a pleasure to join you and talk about life and sports and of course science. So really looking forward to unpacking, I think, two powerful narratives, specifically from the Heart Failure Society of America meeting in Minneapolis, where you were so missed. I think new insights as to aficamten and hypertrophic cardiomyopathy, and then also what we've been fortunate to partner on, how we can reimagine prevention and communication and how our words matter in heart failure.
Yeah, well, let's start with some of the science we saw. And at ESC, they presented the MAPLE-HCM study, and I know you saw a sub-study presented at HFSA, but just to remind people listening, or if they didn't get to see the MAPLE-HCM study, that was a comparison in symptomatic obstructive hypertrophic cardiomyopathy, 88 patients, and they randomized these patients to either metoprolol, which has been usually the medication we use in HCM, or aficamten. And they compared these two drugs over 24 weeks, and they saw using this medication that they were able to improve exercise capacity. They were able to improve New York Heart Association functional class. In fact, more people were able to achieve going from having active symptoms to being in class 1, and they were able to reduce the LVOT gradient. They also demonstrated that there was fewer side effects to the medication, and there was also a reduction in the pro-BNP levels as well as the left atrial volume. So what does that mean now? Because my thought process has always been use a beta blocker first. Does this study answer it and change our approach?
Well, I think, our field is so exciting right now across every aspect of heart failure and hypertrophic cardiomyopathy affecting 1 in 500 individuals in varying degrees, of course, has been a disease traditionally that we didn't know how to modify. Beta blockers, calcium channel blockers were the mainstay of treatment, right? And now, and if you think about all of these cardiac myosin inhibitors like mavacamten, aficamten, and others that are now emerging in the pipeline, the idea was that patients needed to be optimized on beta blockers and calcium channel blockers before we introduce these drugs. And here we have MAPLE-HCM that is using beta blockers as a direct comparator. Yeah. And I think this is where the paradigm is completely shifting, right? We're not talking just about alleviating obstruction. We're talking about retraining the myocardium. So this was a disease that was once defined by limitation, and now we're talking about restoration, more energy, better quality of life, more life, period, hopefully.
Exactly. That's huge. And I think that especially these secondary measures really taught us a lot about the resilience or the cardiometabolic resilience. And I think that's interesting. And then there was a study that I missed. I think it was presented at HFSA, the Forest HCM study. And how did that study differ? And what did they find?
Yeah, you brought me back to HFSA. So Greg Lewis, who's one of the world's experts in cardiopulmonary exercise testing, presented a sub-analysis of MAPLE-HCM, where they, as you mentioned, patients were compared to metoprolol in obstructive HCM. And what he showed in the sub-analysis was that there was an improvement in exercise capacity as measured by peak VO2, as you already mentioned, but it also improved other metrics of exercise physiology, which I think is really important. Anaerobic threshold, aerobic and ventilatory efficiency, peak workload, heart rate reserve, and post-exercise recovery. So I think this was I really like what you just said, which is that it's about restoring cardiometabolic resilience for a patient. So I love that. When you talk about forest HCM, I think it's an interesting difference. I always get confused between these different studies. So Forest HCM, I don't know about you, but Forest HCM was a long-term extension study. So this is different. It's not a randomized active comparator-based study. This is an ongoing open label extension study for people who were in the previous aficamten trial of Redwood or Sequoia. And so this includes patients with both obstructive and non-obstructive HCM. And so what was shown here was, this was presented by Ahmad Masri, is that we are looking at individuals now with non-obstructive HCM. And I think what was interesting about this is that what was presented at HFSA was this 96-week data that showed durability of the improvements that were seen in the original studies of aficamten. Almost 80% of patients improved by at least one New York Heart Association class, and 3/4 of patients, again, small numbers, less than 40 patients, became completely asymptomatic. So I think this is remarkable, really.
Yeah, really changing our whole thought process to how we treat these patients. And I think really, you know, a very patient-centered impact, right? Because patients just want to feel better as much as they want to have a better quality, you know, it's quality of life as well as quantity of life. And I think this is one area we've really struggled with. And now I think that it's also important to point out, selfishly, that both data sets actually of these studies appeared in our Journal of Cardiac Failure. So if people want to read more about these studies, they can look at them there.
Yeah, I love that plug. Thank you. I mean, you've taught us so much about this, right? When you look at Maple and Forest, we're seeing that this isn't just, like we said, relieving obstruction. It's rewriting the story for individuals living with HCM. And it's about us this is an actualization of what we've been trying to push forward at the journal and in our community more broadly, is that it's not about failure, it's about function. So function over failure, right? And I think this connects to how we approach heart failure more broadly.
Yeah, I love that transition. We talk so much about that. And I think because of what we're seeing across cardiology, finally, we're talking about prevention, and prevention is taking center stage. And at ESC, we had a Lancet article. You and I also released just before that our paper in the Journal of Cardiac Failure, as well as in the American Journal of Preventive Cardiology, about heart failure prevention, and specifically talking about a lot in both of these papers about the cardio-kidney metabolic continuum. And we're finally now joining forces because we can all do prevention together, which really excites me.
Yeah, I mean, you really spearheaded this for me, and this has been a dream that we talked about, several years ago, about why are we so siloed, right? And prevention, and as you've been saying for years, and now I think I've come to appreciate, and I hope that we'll see more appreciation for in heart failure, especially as we adopt this cardio-kidney metabolic health framework, rather than just talking about disease. We're talking about maintaining and preserving health and function rather than just treating heart failure. And I think we're beginning to define heart failure prevention as a continuum. What I think is distinct about our statement, when you compare it to the Lancet 3-part series, which is a true tour de force led by Muthu Vaduganathan and others, is that we can think about primordial prevention, we can think about primary prevention, we can think about secondary prevention. Even when you have had heart failure, been diagnosed, you're managing comorbid conditions in a form of prevention, right? You're still treating hypertension, diabetes, CKD, obesity, et cetera, throughout the lifespan, health span of our patients. And then where I think it's so interesting is, even after patients have gone on to receive heart replacement therapies like a heart transplant, guess what we're managing? CKD, obesity, hypertension, diabetes, dyslipidemia. So it really speaks to the fact that heart failure prevention exists across the continuum of a patient's health span. And I think along the lines of what you were saying, trials like Summit and STEP-HFpEF have taught us that by modifying metabolic drivers of disease, we're directly altering cardiac structure and function, thereby leading to better function of our patients.
Yeah, such an exciting time that all our specialties, but I specifically think for heart failure and prevention overlapping. And I never really thought too much, I'll be honest, about the tertiary prevention that you coined, that really is that advanced stages that, we don't necessarily see, but I know you see in your clinic, and you're the one that's managing them, and we're scared to touch anything in them usually, unless we're specifically asked about lipids or something like that, then we might enter the field. But I think that is really changing the thought process, because we are extending patients' lives, and then we do have to prevent the consequence of other risk factors that they're still living with even at that point.
Totally. I think, it's not just about the pharmacotherapy, right? Which you teach us so much and you live. And I've actually learned that from you. And I'm making a bigger effort in my own life and my family's life. It's about lifestyle. It's about nutrition. It's about mindfulness. It's about constant engagement, integrating sleep and stress resilience. And in addition to those comorbid conditions or risk factor modifications. So I feel like if we can redefine this heart failure journey around preservation of function, like we talked about, rather than a reactive nature to failure, we'll start really closing that loop between prevention and treatment.
Yes, and I think when we put it foundationally, at least in our paper, we said it begins with life's essential eights, and that's foundational to everyone, every single patient that we meet. So let's also move to something that I've learned from you. Actually, I think you have written so beautifully and extensively in the Journal of Cardiac Failure about the words matter movement, and I think that is really inspiring. Can you talk a little bit about this? And I know that you saw a very interesting study also at HFSA. I saw you posted it. It links to that, so I just wanted you to maybe give us a few highlights.
Yeah, thanks, Martha. I think, this has been a team effort with Rob Mentz and the rest of the editorial board. It started with something super simple, right? It's just noticing how our language shapes our mindset. And so it shapes our mindset as clinicians, and it also shapes the mindset of our patients. When we say heart failure, I mean, this is a controversial subject in a way, because we don't want to diminish the gravity and the severity of the disease, but at the same time, we want patients to be engaged with us. So moving towards function and talking more about function, I think, can be a really helpful way to facilitate trust with our patients. One thing that I really think that is challenging is we often talk and label patients as non-adherent, right? Rather than thinking about what their barriers to adherence to medications are. And I think that allows us to contextualize where that patient's coming from. Maybe they just lost their job, right? Maybe they need to be home for their children, and that's why they weren't able to pick up their meds, et cetera. So I think that that's an important change in our words. The other thing that we often say in our field, especially when we talk about heart transplant or LVAD, we'll say, oh, so-and-so is not a candidate. And I think we unintentionally convey hopelessness when we do so, rather than speaking to so-and-so may not derive benefit from a given therapy, transplantation, LVAD, et cetera, for XYZ reason. Again, affording that contextualization. So there was a very small study done out of Johns Hopkins, led by Nisha Galotra and some of her house staff, that used some of these editorial pages, which was like so humbling, and it was just so nice to see, to train APPs and medical assistants to use this language as opposed to traditional or conventional language to engage with patients. And super small, it's not published yet. This was just an abstract, but what a wonderful thought, right? Like, let's really measure the impact of changing our words on our patients, on ourselves, and see if it influences behavior, quality of life, perception of illness, engagement, and other things.
That's beautifully said, Anu. And we've really moved from really molecular mechanisms of treating hypertrophic cardiomyopathy to now to prevention, and now to the power of words. And this is the story really of where heart failure care is headed.
I'm like so thrilled to be in this subspecialty. I think the future of cardiology is not just high tech. It's like also just being personal and personalized. I think whether it's precision medicine in HCM or prevention in heart failure, the key is that we're moving forward, but we need to move forward with just tremendous amount of empathy. I think the golden rule is like the best way to practice. Do unto others as you would want to have done to yourself. And I think we're on our way to getting there. It's an exciting time.
Well, thank you, Anu. And I hope to see you and everyone on this call at the Heart of Cardiology, going back to the Heart of Cardiology, which is in Miami in January. Where else do we want to be? See you there.
Thanks so much, Martha. I can't wait to see you in Miami.
Yeah, claim your credit, people that are listening, and we'll see you soon. Thank you for attending with us.